I would like to welcome everybody to tonight's webinar presentation of the Endo A&P. We are joined by Dr. Aumatma Simmons to discuss integrative approaches to recurrent pregnancy loss. Dr. Aumatma is a naturopathic doctor who also has a master's in nutrition, and she has been practicing medicine for more than 10 years. Her practice specializes solely on fertility, pregnancy, and postpartum. So this area that she's talking about tonight is really her bread and butter. She is the best-selling author of Fertility Secrets, What Your Doctor Didn't Tell You About Baby Making, and is a sought-out speaker in this topic of fertility, women's health, and women's empowerment. She has also been awarded the Best Alternative Medicine Practitioner Award, and she consults clients locally in the Bay Area in California, but also works virtually with clients from all over the world. So with that, I will mute my line and pass the floor over to Dr. Simmons.
Thanks so much, Corey. I'm so excited to be here with you all today. And we're talking about integrative approaches to recurrent pregnancy loss. Today, I want to cover kind of an overview of the conventional approaches on recurrent pregnancy loss, or RPL, which I will abbreviate to starting now, and more naturopathic approaches that are research informed and clinically informed for what's actually going on, or what's one of the many reasons of what's happening with RPL and how we can prevent it for our patients. So what I'll start with is just like kind of recognizing, and if you work with a lot of women who have experienced loss prior to them coming to see you, you will notice that a lot of them are super anxious, right? Like so much anxiety about their bodies. Do we trust ourselves? And when they do conceive again, they tend to be extremely anxious about what's happening, and is it going to work out this time, and really like that reassurance that I often feel for my patients to say, absolutely not, we've done everything in our power. And when we get to later in the presentation, I'll share with you what I do to like kind of assuage their concerns while having really tangible data about like, hey, your pregnancy is actually progressing really nicely, and let's not freak out for no reason. I can just tell you, like, I have a patient who has had 2 recurrent losses and is pregnant again, and she's around probably around like 8.5 weeks now, and we've been working on this for a little while, but her nausea went away today. And literally, this is her 4th email this week to me. Her nausea went away, and she's freaking out because she's not experiencing what she was prior to this day. And she says, oh my God, it just went away suddenly. Should I be worried? I'm freaking out. I've never had it go away, you know, like the whole bit that she's going through. And I just let her know, like, listen, from everything that I know about what's happening and how your pregnancy is progressing based on your hormone results, you're doing fine. Like, do not freak out. It's normal. It's okay. Like, there's a point in everyone's pregnancy most of the time where the nausea goes away. So just a lot of like support that a lot of these women who have experienced RPL will need from you if you're working with them. So just be mindful of that and prepare for that from the beginning. So the way that we do that, like we have it built into our programs that after they finish working with us, if they've had a pregnancy loss before, we'll actually include the first 3 months of their pregnancy as part of their fertility plan, because that like continuity is super great, and you as their doctor know the amount of work that you have done to make sure that they have a healthy pregnancy, right? So what's really exciting and juicy for me in this topic is that experience of like, you can rest assured that if you have done all of these different steps in going through the underlying concerns or causes for RPL, you can be the support person that can kind of assuage the concerns of these women and anxieties, really, of these women who are going to maybe potentially feel like they're going to have another loss. So I'm really excited to be with you today. This is a topic near and dear to my heart. I have personally never experienced loss in this way, but what's really funny is that the first trimester of my pregnancy, and actually it continued to like month 5, I felt like I was going to have a miscarriage, and it might be because of the number of people that I've worked with who have had like recurrent loss, that I was kind of like taking on the anxiety for them, and have so much compassion now for what these women are going through. And I just feel really honored that they trust us in the process to be able to support them and get to the other side, which for most of them is getting to the second trimester. We've worked with a few people in second trimester experiencing second trimester loss, but it's pretty low numbers. The majority tends to be that first trimester. So that's really what I'm going to be focusing on today. This is a really interesting depiction of what's happening with the number of women that are actually getting pregnant and the number of losses based on age. So what you'll notice is that there's this steep decline in the number of women that are getting pregnant as they age, and the number of spontaneous abortions or miscarriages or losses are increasing. I guess the other thing that I should bring into this space is just kind of a mindfulness around the word. So I don't imagine that it will trigger any of you if I say miscarriage. It is often a trigger for our patients. So being mindful and just like, I kind of take the lead from them. So if they call it a spontaneous abortion, which is like a very medical term, and most people don't like to refer to it that way because abortion feels like it was by choice, and this definitely is not by choice. But women can refer to it as miscarriage, loss, spontaneous abortion, whatever it is. Just like, be mindful and take the lead from them, because that will make them feel way more heard and taken care of in what it is that they're experiencing. So yeah, I'll just bring that up to put it into the space. So this is continuing on. Age-related incidence of RPL is 1 in 85 in the 20s, and by the time you get to 45, it could be 1 in 2. So there's definitely an age-related thing, but what I find a lot is reproductive endocrinologists as well as OBGYNs kind of write it off as the age-related thing without looking deeper, especially when women are in that like 35 to 40 age range, or 42, 43. It's like the assumption is, oh, it's because of your age. But the fact of the matter is, it can be due to a lot of different reasons, and no one is looking into a deeper reason because everyone is stopped by this age thing. So what exactly is RPL? Recurrent pregnancy loss is defined as 3 or more consecutive losses. So if a woman has 1 miscarriage and then gets pregnant, has a baby, and then experiences a second loss, that does not count. So it needs to be a consecutive number of losses, and 2 to 5% of women are affected. And usually after 2 losses, sometimes 3, depending on the OB, they will actually initiate further investigation for underlying etiology. But again, as I said, a lot of these women are being told, at least the population that we work with, that like 32, 35 to 42-ish is like the bulk of our population. And most of these women are being told, oh, you had a miscarriage, not a big deal. Which, first of all, like if you've had a miscarriage even if it's your first time, it doesn't not feel like a big deal. So they're getting often written off, and there's nobody that's like, hey, let's actually do some work to figure out if there's something going on under the surface that could potentially be going on that we want to address. So that's kind of what's happening. Parental chromosomal abnormalities and antiphospholipid syndrome are the only undisputed causes of RPL, meaning statistically and globally, like that's what's accepted as the reasons for recurrent pregnancy loss, and every other reason or cause that could be going on is disputed. So, and it's disputed even in the research. So I'll show you lots of studies today, and what it'll feel like contradictions, right? Like, wait, you just said this and now you're presenting the study that says the exact opposite. And the reason is because there is no conclusion. So what I will give you at the end of each of those contradictory things is like my assessment and how we deal with it in our practice. But you are, of course, welcome to your own opinion about which way to tend. My sense is that where there is no conclusion, our tendency is to go towards the safer side, or like the more conservative side. But again, you can take your own decisions on that. So basically what like the tiny sliver that is accepted is that genetic factors, that 2 to 5%, and the antiphospholipid syndrome, which isn't even on this graph right here. So the rest of it is unexplained RPL, not related to APS thrombophilias, and autoimmune infections and endocrine. So what I want you to take away from this pie chart is really that 80 to 85% of recurrent pregnancy loss is the stuff that we can help them with, right? Like as naturopathic doctors, we are equipped to help support women to not have another loss. And most of the time, unless they have a genetic or anatomical issue, we have the tools to be able to support them. So that is the other key takeaway out of this, is we can help them. So we need, what I feel like is needed most is so much more awareness around what naturopathic doctors can do for fertility, but for also preventing loss. And really it is, in a way, it is fertility. Like if you're fertile, it's not just about you being able to get pregnant, but that fecundity or that ability to carry to term is just as important. So even the language that we have around whether or not the fertility support that we provide can help them carry to term, it's like, it's part of our conversations when we start talking to them initially as a patient, is like, well, we're not looking at success rates based on can you get pregnant. We're looking at your success is you have a baby to prove that you got pregnant, right? Like it's not just like, yeah, you had a positive pregnancy test, but how did that pregnancy go? And did you carry all the way to term or as close to term as possible? And what, at least what I've seen, is the tools that we have as naturopathic doctors are incredible to help support women who either are trying to get pregnant or more so that can get pregnant but can't sustain a pregnancy. So just a little bit of background, the anatomical factors, Mullerian abnormalities are basically like uterus being not a typical uterus. It has a septum defect, or it's unicornuate or bicornuate, and it doesn't have the normal anatomical structure that is present for most of us as women. Asherman syndrome is basically like scar tissue built up from potentially surgeries, but also IUDs. So this is a really interesting gray area thing of like how often does this happen, and do we need to warn women about it when they are getting an IUD? Currently, I don't think that's really like super talked about, but it is interesting to think about. And then leiomyomas, fibroids, and things like that that can affect the ability of an embryo to grow to full term potentially. I guess, oh, sorry, what I should have said about fibroids also is we technically can help with this, right? I had a patient who had a basketball-sized fibroid in her uterus, and she was advised to remove it. She did not want to do that because the surgery, one, was going to be really complicated. They were going to need to cut her open pretty extensively. So we did all the naturopathic things. It actually shrank it down, but it did not make it go away. So she did end up having to get it removed, but the surgery was way simpler and way more successful because of that. And she did go on to have a healthy pregnancy and a healthy baby. But that, again, fibroids might be something that we could help with. Sometimes they'll have an evaluation with a reproductive endocrinologist and they say, actually, this is not too much of an issue. The fibroid is small, it's outside of the uterus, whatever it is. You don't need to worry about it. I usually take their lead, and it always comes up as part of a discussion because often if they have fibroids, they also have high estrogen levels. So we're going to be treating that anyway. But it's really a call based on how big is it, and do we think we can help this, or are they going to need to get it surgically removed? Genetic factors, most of them are related to balanced translocations, which basically means that the parent who has the translocation doesn't have any signs or symptoms, but the egg or sperm can end up with extra or missing genetic material, which can then result in a miscarriage. The solution that is usually offered is to keep trying and hope for the best. Like, eventually you will have the chances of having that translocation every time is going to be pretty low. So basically their suggestion is keep trying. Or for people who don't have the time, or just really don't want to have that experience over and over again, another option might be to get PGD tested embryos. So basically, if you're going through the process of IVF, they can do genetic screening on the embryos to figure out if they are genetically normal or abnormal. So those are the possible things. I feel like we can't guarantee that this can be something that we would address, but I've definitely seen scenarios where this very well was the reason that people were having a miscarriage or recurrent loss, and doing all the naturopathic things and just optimizing their health and their fertility went a huge way in helping support them to have a healthy, normal pregnancy. So inherited thrombophilias, factor V Leiden, protein CNS, MTHFR, and homocysteine. The first two we won't really talk about because they tend to be addressed through Western medicine, but MTHFR and homocysteine we'll talk about a lot. And then the autoimmune aspect, antiphospholipid syndrome, really in terms of what we need to know, I will admit that I have never actually had to test anyone for APS, because a lot of patients who have had RPL are, if they're coming to us after 2 or 3 losses, have already been screened for all of this stuff. So it's good to be aware of, and good to have if you're seeing someone who is a first-time loss or has not been screened for these things. But generally what I've seen is they do screen for APS pretty quickly. So there's that. Infections, endometritis, and bacterial, viral, fungal, or parasitic infections are all possibilities that could result in a miscarriage, and I'll show you some studies and research on that. Endocrine factors, we will definitely mention PCOS, because 1 in 2 women with PCOS, I think that's the right statistics. I wish I should have looked it up. Or if Dr. McCullough is here, she can chime in and tell us. I believe that it's 1 in 2 women with PCOS that will experience a miscarriage. So those stats are really high, and often what I've noticed is that PCOS goes undiagnosed in a lot of women that do not have the typical PCOS picture. But it's something that we screen for regularly, and it's something that we address a lot in our patients, because 1, not only were they not diagnosed, or they were experiencing all of these things, but they didn't know why. But 2, it is super important for fertility as well as fecundity. So it's definitely something we address. It's not something that I will go into today, because that could take a whole hour or a whole day to really talk about and dive into. And Dr. McCullough did a really awesome job. I think it was last month or the month before. So if you didn't catch her presentation, please do. It was really lovely. And then hypothyroidism, I will talk about a little bit. Again, another topic that could take a whole day to talk about. Luteal phase defects and diabetes mellitus. And I will reference all of the rest of these throughout the presentation today. So hypothyroidism, recurrent pregnancy loss was associated with a TSH greater than 2.5. A study found that 69% higher rates of miscarriage in women with a TSH greater than 2.5. And the Endocrinology Society accepts and actively treats TSH over 2.5 in pregnancy. What's really interesting about this, and I get into these like discussions, debates, whatever, with REs and OBs regularly, because it's often that we see those women in their fertility period and we test thyroid on everybody. And they come in with a TSH that's well over 2.5, and it's not being addressed. It's not even being acknowledged. They have all the symptoms. And then they will go, once they get pregnant, then the doctors are concerned and are like, oh, we got to get your TSH down. If they're working with us, we're already working on getting it down. So it's not really an issue that comes up. But a lot of times I've seen women who are pre-conception being told, oh, you don't need to worry about your thyroid. And then as soon as they get pregnant, it's a complete turnaround. And they're like, oh my God, your TSH is too high. It's a little silly in my opinion, but yeah. So my suggestion is always to start with it in the preconception period. If you have the chance or opportunity, sometimes you will see those patients who come into you already pregnant, hoping that they're not going to have another miscarriage and panicking and all of the things, in which case you can only do what you can do. So yeah. So in a test group of 100 women, TSH levels were significantly higher in the first trimester in women who had had spontaneous abortions compared to pregnant women who had had successful pregnancies. Hypothyroidism is associated also with the increased TRH production and hyperprolactinemia. The hyperprolactinemia Hyperprolactinemia further leads to delayed luteinizing hormone response and inadequate corpus luteum formation, which then leads into egg quality issues. So it's definitely like thyroid related issues with fertility and pregnancy are really super important to address. And then hyperthyroidism, both early miscarriage and late stillbirth pregnancy loss were more common in women suffering from hyperthyroidism. Inadequately treated hypothyroidism in early pregnancy may have been involved in spontaneous abortion, and undetected high maternal thyroid levels present in late pregnancy have attributed to an increased risk of stillbirth. All that to say, your thyroid is really super important. Hashimoto's, this is probably one of my biggest pet peeves. Is most REs, endocrinologists, OBGYNs, the default is to not test antibodies if their TSH is normal. We as naturopathic doctors know pretty readily that just because your TSH is normal doesn't mean you don't have antibodies. So, you know, patients tend to be resistant to testing, and they will push back a little and say, oh, but my doctor tested me for everything and my TSH was totally normal. Why do I need to do this test? We do antibodies for thyroid on everybody because we want to make sure that we're screening for these people. And often it is enough of a issue that we can say, hey, your thyroid antibodies probably had something to do with the pregnancy loss that you've experienced. And it's often a hard pill for them to swallow, but it also is reassuring of like, hey, all right, I can take care of something, or I can do something about this. So there are a lot of studies related to Hashimoto's and pregnancy loss, but in short, women who had pregnancy loss had a higher association with antibodies than women who did not. And that was true with TSH abnormal and TSH normal. So anti-TPO positive euthyroid females had higher prevalence of infertility, anemia, and preterm delivery. Pre-pregnancy anti-TPO screening may aid in early identification of women at risk for RPL. This was a meta-analysis of 17 studies, out of which 14 showed that there was double the rate of miscarriage in euthyroid women who had antibodies versus those that didn't. And what was also, did I not talk about it? Okay, so, and also what was interesting was similar studies that showed that when these euthyroid women with TPO antibodies were treated with, specifically they were testing with levothyroxine, the rate of miscarriage actually declined significantly. So basically, like, you know, it might be advisable for women with TPO antibodies to be on levothyroxine. I've kind of like towed the line a little bit on this, but you know, it's whatever it is that you're doing and however you feel is most appropriate to treat Hashimoto's, you should do that for patients that have Hashimoto's, and even more be assertive about testing these women for antibodies right when they come in, and don't wait, because at least from what I've seen, the antibodies and Hashimoto's in general can take a long, or not long relative, it can take like 4 to 6 months to 8 months to really heal this. So it takes time, and the sooner you know, the more you can help them with this. Okay, so we've talked about a few things on this already. Other things that have been related to unexplained recurrent pregnancy loss um, are we talked about the negative influence of age on oocyte quality, which may be leading to the difficulty conceiving or decreased fecundity in some of these couples. Um, yeah, I could say a lot about that, but I think you probably got the point that I don't think age is the only issue here. And I feel like when we write couples off or women off to you're too old, we're basically missing all of the underneath stuff that's going on that's causing them to be too old. Um, of course, there's some things that you really cannot change, but yeah, like really paying attention to that age-related decrease in oocyte quality and not letting age be the only influence on that. Lifestyle factors, low body fat, excessive exercise or under exercise, really the prevalence of STIs and smoking have all had negative effects on fertility and fecundity. We talked about the other factors, PCOS, fibroids, and endometriosis. Actually, we didn't talk about endometriosis yet. Endometriosis is pretty similar in its stats, like 1 in, I believe, 3 women with endometriosis will have difficulty conceiving. And I haven't looked at the stats on this recently, but there's a pretty good number of those that will miscarry because of the endometriosis. So again, like all 3 of these, fibroids, PCOS, and endometriosis, is something that we can really, really, really make a difference with as naturopathic doctors. And a lot of these women are not getting screened. A lot of these women don't know that they have these issues and have experiences that can like clue you into that might be going on. But we as their NDs can really make a huge difference in the outcomes of their pregnancy if we help them uncover and deal with some of this stuff early on. Genetic influences, this is basically like a lot, if women were, for whatever reason, genes, mother being exposed to DES or things like that in her pregnancy could lead to low ovarian reserve in the woman that's trying to currently get pregnant. And there's not a whole lot that we can do about that. If and this is not exactly correlated, but a woman who has a mother that went into menopause at 50 is probably gonna have, maybe she may not go into menopause till 45 or 47 versus someone else who could potentially go into menopause way earlier because of the genetic influence that she has from her maternal lineage. And that's an area that I've seen less success with. And usually at least I shouldn't say you, but usually when they come in to see us, we're kind of assessing like, is this some issue that we can help with or is it not? And if it's not, then we refer out to other people who can help, or just be honest and upfront and say, listen, there isn't a whole lot we can do for you. But yeah, so those are like, what age did your mother go into menopause, if they know, and kind of assessing their ovarian reserve and like when they started menstruation can give you a little bit of a clue of into, is there a potential genetic influence that's causing their lower number of oocytes. Potentially reduced reproductive lifespan due to postponing childbearing. This is the same like age controversy. And then environmental influences. So dioxin exposure being linked to endometriosis, phthalate exposure being linked to lower ovarian reserves, and BPA which may be interfering with oocyte development and maturation. So all of those environmental things playing a pretty significant role in whether or not only can they get pregnant, but will that affect their fecundity, or will that affect their pregnancy success? So that's a lot of the conventional side. I'm gonna do a quick time check. Okay, I've got 20 more minutes and I better start talking faster. I hope everyone's staying with me. I can't see if you have questions, so just hold on to them and we will address your questions at some point. MTHFR is a really interesting one. There's a lot of debate about MTHFR and whether or not it affects pregnancy outcomes. So what I like to think about, and this is where I said I get pretty conservative, is not only MTHFR, but do they have genetic polymorphisms besides MTHFR, MTRR, MTRRR, COMT? Like there's a boatload of genetic polymorphisms that may not directly influence pregnancy outcomes, but we're not just testing women for MTHFR. Like we do everything, because even though there isn't that like direct link yet, it doesn't hurt to optimize everything that we can possibly optimize instead of just addressing the small little piece. But even within the small little piece, there's a lot of debate. There are some REs that are like, MTHFR is BS, like don't even worry about it. And then there are others that are like, oh my God, you need to take methylfolate and whatever. I've had other naturopathic doctors reach out to me and like debate this idea of, is MTHFR a significant issue or not when it relates to pregnancy outcomes? And my opinion is, yeah, like to me, there's enough preliminary evidence, even though it's debated. There's some evidence that says it's affecting miscarriage rates. So let's just be sure that for the person in front of us, that's not the issue. Versus the camp that feels like, no, we should just ignore this. I don't think that MTHFR or really any polymorphisms at this point are something that we can just ignore. So my perspective is we should do something about it. The one, there's two different alleles with the MTHFR. The C677T, that's the one that seems to be most connected with early or late recurrent miscarriage. And I feel like it's a relatively easy thing to treat. So we should definitely look at it and address it. There was a study, there was a study of 57 of total 173 patients who had MTHFR that were homozygous. And this, I think this study actually found that this polymorphism is associated with elevated serum levels of homocysteine and idiopathic recurrent miscarriage. Oops, sorry. There's another study that, did I put it in here? I didn't put it in here. There's a study that has found the exact opposite, that said C677T did not connect to early or late miscarriage. And then there's this, which I feel like is the middle ground really, where they didn't just look for MTHFR, they kind of grouped these people that had MTHFR or hyperhomocysteinemia, which is surprisingly common. We also test everyone for homocysteine levels, and usually, like, my rule of thumb is if they're below 7.2, we don't generally worry about their polymorphisms. If it's between 7.2 and 10, we do a lot of like diet and lifestyle and some like generic supplemental support like nutrients. And if it's above 10, I usually want them to go and either do 23andMe or whatever genetic thing they want to do. Some people are really anti the sharing of genetic information. So there's lots of companies out now that keep all of the genetic data confidential. So I usually give them the option, but basically I encourage them to do the epigenetic or polymorphism testing so that we can know which exact genes or alleles are impacted, and kind of have a very creative strategy around treating those. So this found that people who had hyperhomocystinemia or MTHFR, they treated with folate, B6 and B12. And then the people who had thrombophilias, they treated with, I believe, aspirin. Yeah, low dose aspirin. So what they found was that they were able to, through the treatment for both of those groups, they found that the unexplained pregnancy loss rate was much lower after they got the treatment. So I believe that it's worth it to treat when you know that something is an issue. Luteal phase defects. So this is the other controversy that I've seen a lot is, and I know that a lot of NDs are treating people with progesterone supplementation if they've had a miscarriage. And my personal opinion on that is we may not be practicing research-informed medicine. And the reason that I say that is I've seen enough, and I think I'll share in a little bit, there are studies that actually show that progesterone supplementation in women who got pregnant naturally, it had no outcome effect on the pregnancy. So it was really only the women that were treated with IVF that had the benefit of taking progesterone. So from the beginning, I've kind of questioned this, like, just throw progesterone at everyone, and like really like think about when it is that we need to supplement progesterone and when it may not actually be making any difference whatsoever. And the only reason to do that is it's a pain in the butt. Like, if you've ever done progesterone suppositories, you know that this is a pain in the butt. Like, the number of women that complain about it and like, oh my God, can I stop doing this, is really, really high. So it's not a pleasurable experience. And if they don't need to, do we really need to push them onto progesterone? And that's really my question in all of this is there something else that we could be doing that could eliminate the need for progesterone supplementation in women who are getting pregnant naturally? If they're getting pregnant by IVF, they definitely need to be on progesterone. That's a whole different issue. But we're really talking about that segment of population that is going to conceive naturally, and when do they need progesterone and when do they not? So progestation is literally the meaning of progesterone. It helps with the implantation of the embryo. It plays a role in maintaining pregnancy. Inadequate secretion of progesterone in early pregnancy has been linked to miscarriage, and progesterone supplementation has been used as a treatment for threatened miscarriage to prevent spontaneous pregnancy loss. So those are all the things pro-progesterone. Estrogen and progesterone have a great role along with other hormones. Progesterone has been shown to stimulate the secretion of Th2 and reduce the secretion of Th1 cytokines, which maintains pregnancy. Supportive care in early pregnancy is associated with significant beneficial effect on pregnancy outcome, blah, 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 blah. All of this to say, there's some evidence that suggests progesterone could be a really good thing. And And then this is the study that talks about progesterone for supplementing in women that did assisted reproduction versus those that did natural conception. Progesterone production from the corpus luteum is critical for natural reproduction. Progesterone supplementation seems to be important in every aspect of ART, and luteal phase deficiency and natural cycles is a plausible cause of infertility and pregnancy loss. So this, like, the smaller segment that we're talking about is women that get pregnant naturally but have a luteal phase deficiency. And do we just supplement progesterone for these women? This is saying more of the same, so in the interest of time, I'm going to skip over it. And then this is the exact opposite. So there's no evidence of first trimester progesterone therapy improving outcomes in women with a history of unexplained pregnancy loss. And this is a whole study that they did with giving progesterone in the first trimester. They were using 400 milligrams starting at no later than 6 weeks into the pregnancy. And basically what they found was progesterone therapy in the first trimester of pregnancy did not result in a significantly higher rate of live births among women with history of unexplained recurrent miscarriage. So this really brings into question, like, what are the other reasons for the pregnancy loss, and maybe it didn't have to do with progesterone. I will say that when women come freaked out or anxious that they're pregnant and they're going to have another loss, in those scenarios, we will generally tend with very minimal progesterone supplementation, like 30 milligrams, and often start regular testing. And we generally do this for all pregnant women who have experienced a prior loss. We'll generally be testing them from the point where they get a positive home pregnancy test to till the end of their first trimester. And I'll generally decide, like, based on the level of anxiety and the hormone levels, whether we should do a weekly test or a every other week test. But generally, we're measuring beta HCG and progesterone in these women in serum. It's just the easiest, and generally insurance covers it. So we'll be measuring that weekly or every other week in pregnant women. And then those women who come in pregnant, who have not done all of the preconception care and all of that, we'll test them relatively quickly and kind of use the same protocol. So what I find is that when we start testing women, what I have noticed is that if their progesterone levels are in a good place, and normally I say, like, the first, within like week 5, week 6 of pregnancy, you're really, you're going to be around 18 to 20, maybe 22. That's a good number. And then generally what I want to see is that it's slowly rising or just maintaining steady at a consistent level. If it starts to decline, that's usually like a really good marker of, hey, their progesterone's going down, we're going to supplement. And we'll generally do like a 200 to 300 milligrams suppository, depending on how quickly that progesterone has dropped. So let's say we tested them this week, their progesterone levels were at 22, and then next week she comes in and her progesterone's down to 18. That's going to be an indicator of, like, yeah, maybe we just need to support this a little bit. And for someone with that small of a drop, I might say like 100 to 200 milligrams, depending on what else is going on for her. Is she feeling nauseous? That kind of stuff. And then for women who are not showing that, like, let's say their progesterone is staying steady at 22 and she's not anxious, we won't supplement at all. It may start going up 25, 31. This is like a real live patient. That's why I remember these numbers. There's a woman that I'm treating right now who's pregnant, but this is the case I was talking about earlier. She's had 2 pregnancy losses. She's got Lyme disease. She's like super complicated case, and she's freaked out. Like, this woman is anxious beyond belief. And for her, her first progesterone level was 18. The next one actually dropped. Actually, no, the next one was like 21. And then the third one had dropped just a little bit. It went down to like 18 or 19 again. And I basically was like, hey, what did you do different? What happened? She was on like 25 milligrams of progesterone, which is really, really low. And part of that was just to like appease her anxiety of like, hey, here's something you can do to support this pregnancy. And then I saw that number go up, and then it started to go down. And she also was measuring her temperatures and was messaging me very quickly to say, oh my God, my temperature is going down. What should I do? And it just so turned out that she self-regulated. She was having difficulty sleeping, didn't tell me. She said, oh, it started after the progesterone, so I just like stopped taking it. And or she like cut the dose in half thinking that would help her sleep. And sure, that helped her sleep, but her progesterone actually started to go down. And that's my suggestion, was just like, take it in the morning instead of night. And she tends to have these like reverse reactions to things. So I was like, okay, it's not totally unexpected, a little bit unexpected, but it's fine. Just take it in the morning. Let's see if that doesn't disturb your sleep, and go back to the dose I'd given you. But it's such a minor dose compared to what we could be doing, which is like 200 milligrams, 400 milligrams of progesterone, which I don't know is necessary. She's now 8 weeks, 8.5 weeks, and her progesterone is at 31 this week. So we're fine. Like, her body is doing what it needs to do. The progesterone, the small bit that I'm giving her, is really just to like appease her anxiety and like have her feel empowered. With a different woman with the same numbers, I maybe wouldn't even continue having her on progesterone. Her body's doing what it needs to do. But so all that to say, really, like, it is a case by case decision. And I don't know that giving progesterone to every woman just because she's not getting pregnant or is not able to stay pregnant is the solution. I already summarized this. So my approach to this is really considering that egg quality, like the level of progesterone is coming out of the corpus luteum. After the egg is released, the shell that's left over is really what's producing the progesterone for the first trimester of pregnancy, until in trimester 2, when the baby takes over the production. So that first trimester is really dependent on the quality of the egg. So if you have worked on egg quality before they conceive, and really they need to be solidly working on it for 3 to 4 months, if they have done that with you, then you maybe aren't going to need the progesterone. And the way that we figure out, one, if it's changing and improving, is the luteal phase getting longer? Because when you have that short luteal phase, it's below, ideally you have a luteal phase that's like 10, the minimum is 10, ideally 12 or 14 days. If they have a shortened luteal phase, that's a really good reflection of there's probably an issue with egg quality. And when you work on egg quality, that luteal phase should expand. That's always my first and foremost step. This was in here for review. So I basically summarized it in the first part, but where you see that growing follicle, and then the part in the middle where the ovulation happens, the egg drops, and that corpus luteum is really what's producing the progesterone. that helps to sustain that luteal phase. So this is my egg quality cheat sheet. These are all of the things that basically are what is suggested by research to support egg quality. And do you need to give this to every single person? No. I do not load my patients on 1,500 milligrams of acetyl L-carnitine along with everything else here. But I will usually pick one or two of these things based on either if they have sleep issues, it's absolutely going to be melatonin. That's like an easy, hey, we're going to support your egg quality while we support your sleep. Done. Awesome. And ideally, we're supporting their melatonin, their internal melatonin production, because even though supplemental melatonin has been shown to improve egg quality, I imagine that really supporting their internal melatonin production really has a lot more to do with egg quality. Because this could be a whole another topic, but because that cortisol and melatonin are kind of in balance with each other. So when melatonin is low, almost always their cortisol is high, and that's what's causing the melatonin to be low. So helping them shift out of that stress mode and more into a balanced state with their cortisol will help support the production of melatonin internally while you're supplementing it. After that, the green tea is also really easy to do. It's often, if you have not heard of this, my general recommendation of green tea is drink 1 cup, start with 1 tea bag or 2 tea bags in a cup, and then re-steep those same tea bags throughout the whole day, because it's really in those later steeps that you're getting the antioxidants out of the green tea leaves. And then if you want to take it a step further, there's quite a bit of data showing that the amount of fluoride in the actual bags of teas is really high, as well as other chemicals that are sometimes in those tea bags. So sometimes it really depends on the patient. Like if they're already drinking green tea, we might take it a level more. If they're not, we may not stress them out about this. So it really depends on who the patient is, how much bandwidth they have, all of those things. But sometimes it's helpful to try and get them to steep actual green tea leaves rather than tea bags. And then often the other recommendations for supplementing for egg quality will depend on testing to see what their levels are. So something like SpectraCell or Cell Science Systems or Genova, who can do like a nutrient analysis to show what levels they have of different nutrients, is really super helpful. Because what I find with a lot of these patients is that they're coming in already taking CoQ10, already taking alpha lipoic acid, already they have heard about these and will take whatever these supplements are. And the downside of that is, hey, they're still not pregnant. Their luteal phase is still in defect. So there has to be some missing piece of the puzzle. And what I find is that almost always through testing, we find like, oh, you're actually deficient in vitamin C, which is just as important of an antioxidant as CoQ10. CoQ10 just gets a lot of bandwidth on research and what people are talking about in social media and the whole bit. So everyone thinks CoQ10 is going to be the thing to help their fertility. But in reality, it's all of these antioxidants that are working in cahoots with each other. So really figuring out like, oh, you're actually really low on resveratrol, and supplementing that is going to give them the best bang for their buck, rather than supplementing every single one of these things without knowing which it is that they're deficient in. So if egg quality is a significant issue, then you want to make sure that you're testing to figure out which one they need. Turmeric is one of those that's got a lot of contradictory studies on whether or not it's supporting egg quality. I, again, will use this as on a case-by-case basis and tend to use it more where we need to stabilize immune function, not worrying about the studies that say it lowers fertility, but I won't use it in everyone. So I don't have a everyone protocol. It's very specific to each individual. I'm going to snap out of this for a second because I need to move to the control panel. I'm noticing that we are at time. I'm hoping that if you guys can stay with me, great. I've got a lot more to talk about. So I'm going to keep going. And if you can't stay, it's totally fine. We will have this recording to play later. So is the uterus sterile? It's been previously said that it is sterile. There's evidence that the origin of the endometrial microbiome might be happening via seeding by vaginal microbes. So maybe it's not actually sterile. Vagina is generally highly acidic, and it inhibits the growth and colonization of other pathogenic species. And lactic acid also suppresses the production of inflammatory mediators in the vagina, which is really important. What's really cool is that we're discovering that the vagina is very, very different from the gut, where in the gut, we're really looking for a high biodiversity. In the vagina, we're trying to limit the biodiversity. And really, like, most of the studies are showing that the prevalence of decreased lactobacillus species in the upper reproductive system cause increased inflammation, may impact implantation, and may cause placental trophoblast invasion. It's basically like halt the growth of a normal embryo. Group B strep, blah, 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 you can read this later, but basically GBS led to increased rates of miscarriage, stillbirth, and preterm labor. E. coli, increased intrauterine inflammation, which then makes it harder for embryo to implant, as well as growth or the fecundity of that embryo. And then, not to leave the men to the last, but seriously, what about the men, right? What are we taught? Like, what is it about the paternal DNA? So this study was really cool. It found that this SSB it stands for sugar intake. I can't remember right now what the SSB was, but it was basically like they were giving these men or seeing if these men had increase in sodas or sugar intake, and where they had a like greater than 1.3 servings per day had much lower percentages of progressive sperm motility. It basically made the sperm lazy. So that is very, very interesting. Another study with metabolic syndrome, and they found that men who had metabolic syndrome and had higher seminal insulin levels had decreased fertility. They actually had decreased, I'm going to say this all twisted. They had increased DNA fragmentation and decreased fertility, and these couples had an increased rate of miscarriage. Oxidative stress affects the sperm DNA. What else is important here? That's about it. There is a lot on DNA and reactive oxygen species. So just like there's a debate in the more conventional reproductive endocrinology world of whether or not DNA fragmentation test is useful. And I keep finding more and more studies that are showing that um, men, there's actually a really cool study in here. Men with normal sperm factors, so on a semen analysis, they actually had normal counts, normal motility, and normal morphology, had high had high levels of DNA fragmentation. And if we're not testing for DNA fragmentation, how do we know? So this, I got really interested in this because I have a patient who had to go through extraction because his vesicle tubes are blocked. So he can't, there's actually no sperm coming out in his semen, but they're able to like go in and extract the semen. And they put this couple through a whole IVF cycle without testing DNA frag. The woman is 42 but has really amazing hormones, like everything's really good. She had a whole bunch of other things that were like low cortisol, like low adrenal function, a thyroid issue. But from the conventional marker point of view, she looked amazing. And they took her eggs, took his sperm. I think they got like 13 or 15 eggs and none of them fertilized. And their response was, oh, it's because of your age. And I asked them in their very preliminary conversation, did you do a DNA frag? And they were like, what's that? And I was like, so you've been working with this fertility clinic for over a year. They have extracted all of the sperm but never tested the DNA of the sperm. And it turns out after we did the DNA frag, his fragmentation rate was really, really high, which meant that his sperm were not producing well. So even with all of the semen analysis markers normal, you can still have high DNA fragmentation, which then leads to, and this was another cool study, like a private IVF clinic that reviewed 475 cycles that they'd done, and they SDF stands for sperm DNA fragmentation. If it was below 30 or above 30, and what they found was that fertilization rates between the two groups were similar, but they had lower rates of cleavage speed, which basically means how quickly the embryo is divided, and lower quality of day 3 embryos. As I said, similar pregnancy rates, but 2.5 times the miscarriage rate. So really, like, we have to look at the guys, and we probably need to do deeper analysis for the men. So I don't necessarily do DNA frag on everybody. I usually have a few like key things that I'm looking for to figure out if we should do a DNA frag. But every guy needs to test his insulin, his fasting insulin, fasting glucose, figure out the HOMA IR, and like, does he have metabolic syndrome, insulin resistance, whatever it is, like kind of figuring out the full picture rather than just assuming that because the semen analysis is normal, there's nothing going on under the surface. Every guy also gets LH, FSH, homocysteine. So we're doing a whole bunch of markers that are really like basic markers, but can indicate a lot about the quality of the sperm that he's producing, even if everything tested normal. These are all the things that can lead to male factor infertility. And then this is my cheat sheet for the guys. And I would say that I tend towards a similar approach, like if they've not had any recurrent pregnancy loss, if the guy's sperm are totally normal, then we might do a supplement that has some of these things in it. And it usually will be 1, maybe 2 things. But if they've had loss before, we're actually going to do way more analyses, and we're going to figure out where the deficiencies are before we start supplementing. So in conclusion, there are many factors related to RPL, many of which we can treat. as naturopathic doctors, especially if people come in during the preconception phase. Progesterone can be useful in some cases after you've addressed all the underlying causes. Address and optimize the epigenetic factors, not just MTHFR. Support the vaginal and uterine microbiome. And then make sure to take into account all of the male factor stuff in addition to everything that's going on with the woman.